Good morning, everyone. Today, our topic of discussion is SLE, or it is called as systemic lupus erythematosus. Now, um, systemic lupus erythematosus, it's a multi-system disorder in which they develop arthralgias and rashes, which are the most common feature of this condition, as well as many other signs and symptoms because this is a multi-system disorder. Um, so now I would like to start the topic with a clinical scenario, and you can see over here a 26-year-old woman with no prior medical history presents with a 3-week history of joint swelling and stiffness. She points to all her PIP, which is proximal interphalangeal joints, as well as the metacarpophalangeals and wrist. She informs you that she has had stiffness for about 2 hours every morning since these symptoms started and that the symptoms improve as the day progresses. She denies back stiffness or back pain. She has fatigue and low grade fever. On examination of the wrist, MCPs and PIPs, they are red and swollen on both hands. The DIPs are not involved. There is fluid in the wrist joints, otherwise, the examination is normal. Now, like when you see any scenario like this, or when you read any scenario like this in the start of the condition, so uh, you know um, how the condition looks like basically becomes so clear in your mind, and it is helpful in remembering many of the clinical features of the condition. um, Now you can see again one more scenario in this one. A 35-year-old woman is brought for the evaluation of confusion for a day. Her friends and family inform you that she did not know how to come home from work and that lately she has not been herself. You found that the patient have elevated blood pressure, decreased air entry on the right lung base with dullness of percussion, and symmetrical joint swelling of the wrist and MCPs. The chemistry profile shows an elevated creatinine of 2.5 milligram per deciliter, and there is protein in the urine on the urine analysis. So this one is like another case in which like there is the lungs involvement as well as there is the kidney involvement, right? And also some neurological features. So uh, I would like to start with um, what you can say the definition. Now you can see like the definition is quite extensive here, what's written over here, but SLE can simply be defined as it's a multi-systemic autoimmune disease. Okay, it's a multi-system autoimmune disease of unknown etiology. Okay, so like the exact etiology is not known. What is known, like I will, of course, I'm going to discuss that. So um, now you can see it's a chronic autoimmune disease, makes sense. Autoantibodies again makes sense. Multiple organ or multi-system damage is there. And now this is the more important point. Like this one is very, very, very common in women than men. To tell you, women to men ratio is 9:1. So, which means most of the patients which you are going to see is women, not men, because it is 9 times more common in females than males. And the disease can affect all the ages, but commonly it is present from 20 to 45. Now, the condition is worldwide, guys. The important thing, okay? Um, Now, the important thing to know about this condition is what we know about the etiology. Now, as you can see, like this is a very uh, simple, you can say, description of the condition. See, there is formation of auto antibodies, and there will be cytotoxic antibodies, there will be immune complexes. So the cytotoxic antibodies will cause cell damage and death, and immune complexes, they cause inflammation. But if you will see over here what is going on, simply they have um, the T cells, the drugs, the hormones, some environmental factors, and genetic conditions. So, if I like talk more about this one, what they found is they found like multifactorial etiology. But now, see, all these etiologies are present in many people, but they never develop systemic lupus erythematosus. That's why we don't know like how, why it occurs in few other people. That's why they say like it is a multi-system disorder of unknown etiology, right? If you will pay attention over here, okay, starting from what you can say the genetics. So they say like the HLA, B8, and DR3 are associated. HLA, B8, and DR3. And why? I explained this thing in rheumatoid arthritis already. And also they found like, simply what's going on is like when someone in the family, they have this condition, so there is higher chances that it will be present in other members as well. So that's the reason, like, genetic things play role in this one. Okay. And also they found like a higher rate in, for example, monozygotic twins as compared to dizygotic twins. So, which again makes some sense. Like when the monozygotic, they have higher chances than the dizygotic. So of course, like there is some genetic linkage, right? So as I told you, HLA, B8, and DR3, not just these, like they found some other associations as well. Okay. So they found like some of the people who have like deficiencies of some complicated complement genes, they have increased chances of developing this condition. Okay. Okay. Before like talking more, I can show you this one. See, here it is a very, you can say, detailed type of um, picture in which you can see the genes, right? And see this one, C1Q or C2 or C4. What is this one? Is basically these are the complements. Okay, so when someone have deficiencies of these complements, they have higher chances of developing SLE. And you can see like the same thing, HLA D238. Okay. They have higher chances, and many more things like are written over here, right? Interleukin 10 and stuff like this. And you can see like the environmental factors, what they're talking about here is um, like UV radiations. Okay. One of the thing like they found, which is an environmental type of factor, is cigarette smoking and vitamin D deficiency. Okay. They are all give higher chances of developing um, this one. And infections also play a role, especially the viral infection. Here it is written EBV, Epstein-Barr virus. Okay. These all can also play a role. So again, abnormal immune response, and there is antigen, T cell, B cell, and the B cell are the one which basically form like autoantibodies, and then they have like, of course, these things we are going to discuss in more detail. So genetic, environmental factors, ultraviolet radiation, stress, vitamin D deficiency, smoking, infections like viral infections. Okay. Hormone factors they found, like what kind of hormonal factor. Of course, like it's more common in females, so they found estrogen. Okay. Why? Because what they found, like there is increased chances of developing SLE after puberty. So simply, and decreased chances after menopause. So what is the hormone which is too much after puberty and before menopause? It's estrogen, right? And one of the things they found in men especially is all the men, when they develop SLE, they have like higher concentration of estrogenic metabolites in them. So that's why they found like you can say estrogen plays some role, right? Of course, like it's unknown etiology, so we cannot discuss like what's the thing which is leading to these things. So we can just talk about the things which we know. Drug-induced lupus is very, very, very important topic. So we call it as drug-induced SLE. So many drugs, for example, hydralazine, which is an antihypertensive drug, or phenytoin, which is an anticonvulsant drug, then procainamide, which is an antiarrhythmic drug, isoniazid, and oral contraceptive pills. They can give lupus-like syndrome, and that's why. And what is the important thing? In like when we will study the diagnostic of systemic lupus erythematosus, one thing which we are going to discuss is simply uh, we will be discussing about what are the auto antibodies which we check in the patients, right? So, for example, we check ANA, we check like anti-dsDNA, okay, double-stranded DNA antibodies. One of the antibodies which we check is anti-histone antibody. So, when it is drug-induced systemic lupus erythematosus, they have anti-histone antibodies. Okay, but the good thing about this kind of SLE is like when we discontinue the drug, their symptoms they resolve. So that's the best part you can say, about this condition. So uh, like there are many studies, guys. They do, of course, like uh, they found like it is more common in African Americans, or like of course like the Americans when they conduct studies, and Asians over there. And one thing they found, like this condition have a bimodal type of mortality pattern. Okay, so there are many things like because this condition is a multisystemic disorder, so they found and they see a lot of things, and what you can say, uh, they found like all the things, they play some role, but again the main etiology remains unknown. So guys, like the important thing, I will scroll down the slides, right? But um, like maybe I will not follow what's written over here, because pathogenesis, like if we will go into a detailed pathogenesis, of course it will take a lot of time. But to tell you, like autoantibodies or immune complexes, we all know how they are formed, right? For example, uh, this one is a normal glomerular loops, and this one is like when there is immune complex deposit. So see, like it is all inflamed. Okay, and they found hematoxylin bodies, as well as onion skin lesions. Sorry, this one is like a mistake. So onion skin lesions they found. Of course, like the pathophysiology of this condition is like, if you will go in too much details, it will be a lot. But we know, like whenever the cell die, there is a process called as apoptosis which occurs, right? And what happens, once the cell die, the cell remnants, they appear on the cell surface. Okay, and of course, like all the cells have antigens, as we know. So what happens is like these antigens have basically the nuclear material as well. For example, the DNA or the histones. Okay, so which are normally hidden from the immune system, right? Now, what happened when in the patient of SLE? Um, Basically, the removal of these cells by the phagocytes is not efficient, simply. And once they are transferred into the lymphoid tissue, so basically these cells which are dead by the apoptotic or by apoptosis, they are taken up by the antigen presenting cells. Okay, now when these antigen presenting cells are going to present it to the T cells, and the T cells, when these antigen presenting cells are going to present to the T cells, and these T cells are going to, in turn, will in turn stimulate the B cells to produce auto antibodies, okay, against the antigens, okay, against these antigens, which are basically the cells belong to the body, okay. So now these autoantibodies will start damaging, of course, the body own tissues, simply. Okay, this is like what's going on. So now, of course, like that's the way how it helps us in diagnosis of systemic lupus erythematosus as well. Um, like we check the ANA or anti-DS DNA, of course, like these are the autoantibodies, right? So simply like these autoantibodies, when it is formed, okay, uh, they will form, they can make antigen antibody complexes, and they can be circulating in the circulation. And once they are circulated into the circulation, they can go and they can damage different parts of the body, especially the kidneys, right? Not especially the kidneys, like any part of the body, including the kidneys. So this is like what's going on in SLA. Okay, and then they found like there is some abnormal cytokine production as well. So, for example, interleukin 10 is produced too much. Okay, and many other things like alpha anti interferon. Okay, and of course, like they cause more and more and more inflammation in the body. Okay, so all the things which are I show you, of course, like, this inflammatory reaction, of course, like this antigen antibody complexes or the cytokine storm or the release is going to cause inflammatory reaction. It is going to cause vasculitis. Okay. So, like the inflammation of the vessels. And of course, like these vessels, whatever like they are supplying, when they are inflamed, they are necrosed, they are going to damage that structure. These auto antibody immune complexes, antigen antibody complexes, can be circulating in the circulation and can go and damage the kidney as well, or immune complexes. And what are the hematoxylin bodies? Like these are basophilic staining bodies. Basically, they are the nuclear debris and often associated with anti-nuclear antibody. Okay, and onion skin lesions, because see, like the skin is like hair, like the appearance is like the onion skins. So this one is like the fibrosis of the walls and the surrounding tissue of the central arteries. Okay, because of inflammation, of course. And one of the things they can cause is non-bacterial endocarditis. It is also called as Libman's sac endocarditis. You can see over here. So what happens? Like, see, you can see the small deposits over here, right? So these are basically the immune complexes deposits which are found on the chorda tendineae. Okay, and they are sterile, they are not infective, they are not bacteria, they are not things like this, right? So this thing occurs. So that's like, of course, renal pathology and all this stuff, of course, like the renal damages occur. So there could be extensive crescent formation and substantial glomerular interstitial scarring. Now guys, like if you had gone through my lectures of nephrology, in which I try to explain you why there is glomerulonephritis, what kind of glomerulonephritis is there. And again, like this one is a WHO classification of the renal damage. You can see class 1 is minimal mesangial lupus nephritis, class 2 is mesangial lupus nephritis, and class 3, class 4, class 5, and class 6 is sclerotic lesions. So simply like you can say like these are the main pathophysiology as well as how the condition present. Um, Now guys, like what we are going to do next is we I discussed the pathophysiology. Remember guys, all the you know conditions which are autoimmune conditions, or in which like these antigen antibody things are going on, to understand how they are formed, you must have the basic knowledge of immunity. And once you have that knowledge, of course, you would know, like, how the body, what are the antigen presenting cells, how they present the antigens, and what the T cells or B cells do, and how the antibodies are produced, and how the viruses are killed by that system, and what is the complement system. uh, it takes some time, of course. It's hard to listen to lectures for 1 hour, 2 hours, things like this. But what I found, like, uh, I was also having difficulty in understanding these things, not now but very in the beginning. So I spend, like, you can say, 2-3 hours on complement systems, and 2-3 hours on the immunity lectures, 2-3 hours on the T cell B cell functioning, and the things become quite easy. And once you know the basics, then the things are quite understandable and easy to understand. So simply, once you know that, okay, what's going on in SLE is simply the cells which are dying, the system is defective. Now, why that system is defective, we don't know. Like, why the body own antigens are processed by the antigen presenting cell, and they are presented to by the antigen presenting cell to the T cells, to the B cells, and why. And no, not why. And then they form the autoantibodies, which will go and started damaging the body own structures, right? So this is the main thing, you can say, to understand, to like what's going on with the body. So anyhow, we are going to talk about the clinical features now. The clinical features are quite extensive. Why? Remember, it's a multi-system disorder. So when it's a multi-system disorder, so of course it is damaging, or it is causing harm or damage to all the systems of the body. No matter, it's like systemic features. It is going to damage the renal. It will give systemic features. It is going to damage the renal system. It is going to damage the skin. It is going to damage the musculoskeletal system. It is going to damage the vision. It is going to damage the heart. It is going to damage the vessels. It is going to damage the respiratory system. It is going to damage the gastrointestinal system. It is going to damage the neurological system. So simply, whatever you will think of, it is going to damage that. So of course, like, the things are, like, you could say, quite long, right? Now, for example, I will show you this photograph, right? See, what are the dermatological manifestations? Okay, they have alopecia, right? They have butterfly rash. Now, butterfly rash, like, if you pay attention over here, see, this is a butterfly rash. This is a butterfly rash, right? So they have the butterfly rash. They have the discoid erythema, or discoid rash, you can say. Erythema is redness simply. They have palmar erythema. They may have mucosal ulcers. Now, many of, like, they had, like, this is basically, it's a photosensitive type of rash. Okay. Now, one of the thing to understand over here is, we will talk about a lot of sign and symptoms, guys, a lot. But you must remember, what are the common signs and symptoms. For example, the butterfly rash, which I show you, it's a photosensitive type of rash. This butterfly photosensitive type of rash is present in 85% of the patients. Okay, this butterfly photosensitive rashes present in 85% of the patients. And you can see the butterfly rash over here, right? If you will pay attention on this one, what you will find that the distribution is on the cheeks, okay, across the bridge of the nose, which is the characteristic of this rash, okay. But one of the thing, if you will see over here, that this butterfly rash, see, the nasolabial folds, they are spared. See, here or here or here, okay, they will be spared, right? So this is one of the skin manifestation. Not this is not the like only skin manifestation. Of course, like they may have urticarias, they may have rashes on the fingers, they may have purpuras. Okay, Um and what is photosensitive rash? Simply when they will they will expose themselves too much to the sun, the the rash will be exacerbated. Okay, so palmar erythema or palmar rashes, alopecia, right? All these things are present in the patients. Now you can see the cardio um, pulmonary involvement over here. Now, when it is the cardiopulmonary involvement, you can see they may have ligament sac endocarditis, they may have myocarditis, they may have pericarditis, they may have pleural effusion, they may have pneumonitis, they may have Raynaud's phenomena. Okay, ligament sacs endocarditis, I show you the photograph, right? Of course, it's a non-bacterial type of endocarditis. So, though these symptoms are not so common, 25% of the cases they get this thing. Okay. Now, the important thing to over here is like simply Raynaud's phenomena. Now, if I will show you what is Raynaud's phenomena, you can see over here. This is basically Raynaud's phenomena. Okay, so this is basically uh, you can see like this one is the vasculitis they are showing you. This one is like the vasculitis around the nail peripheries. This is livido reticularis, which is again a dermatological manifestation. This is erythema nodosum, and this one is Raynaud's phenomena. So, what is Raynaud's phenomena like? See, you can see like these the color of this one is normal, but this one is like congested, right? So we call it as Raynaud's phenomena, and the like it can lead to necrosis and gangrene as well. Okay, but like in very severe cases in the patients. So. Now this is one of the feature, right? So not so common, you can say 25% of the patient. Then see glomerulonephritis, hematuria, proteinuria, right? Hypertension, okay, even renal failure, right? So they can go to into renal failure. Now this glomerulonephritis again can occur in 30% of the patients. Not all the patients they get this thing. Okay, not all the patients they get nephrotic syndrome, or sorry, glomerulonephritis. So just few of the patients they have this thing. Um, what happens is basically I show you the WHO classification, right? So what happens is basically if you know what is glomerulonephritis, you can know like we had done that glomerulonephritis in nephrology, right? So you must know what's going on, and we get the red blood cell cast. Okay, we can get hematuria and things like this in the patients. Central nervous system or neurological system, 60% of the patient they get this thing like stroke, seizures, peripheral neuropathy, psychosis, and organic brain disorder. So you can say like they may have seizures, they may have psychosis, they may have headache, they may have transverse myelitis. So what happens like these are the patients, what you can say, like of course like there is some immune complex deposition, there can be thrombosis, okay, or there can be inflammatory microvasculitis or vasculopathy, okay, which we can found in these patients, and due to that of course like the CNS signs and symptoms they appear. Hemopoietic system, you can see uh, 75%, so like it's an important clinical feature. Now what kind of hematological problems we can see in these patients are basically when we check their bloods, they have anemia, leukopenia, lymphadenopathy, splenomegaly, and thrombocytopenia, right? So uh, what you can say, these are the findings we can of course can get onto the labs. Okay, so basically they have hemolytic anemia, They have neutropenia or leukopenia. You can say both are same. They may have thrombocytopenia. They may have, it can lead to thrombosis. Okay, so this is like one of the manifestation of this condition. Okay, or you can say the uh, hematological manifestation of this condition. So until now, if you remember, dermatological manifestations are quite common, hematological manifestations are quite common, and then central nervous system are quite common. Okay, I am leaving this thing because these are the most common signs and symptoms, and I'm going to talk about this thing in the end. Okay, gastrointestinal system, if you will say, many people, they have abdominal pain, but not too much, like 20% of the people. They present with diarrhea, dysphagia, nausea, and vomiting, right? Uh, we can also call it as SLE enteropathy. Okay, so you can put hepatomegaly and splenomegaly in gastrointestinal system as well, and simply like, of course, there is mesenteric vasculitis, which produces inflammatory lesions in the small bowel, which can lead to infarction and perforation. Okay, so of course, like, due to that, this thing can present. Okay, reproductive system, guys, you can see over here, the females, they have menstrual abnormalities, right? So, and one of the thing you can say, which is the last one, is musculoskeletal system. Now, musculoskeletal system basically present with polyarthralgias, polyarthritis, okay, myalgias, okay, and synovitis. Now, if you will see over here, is basically, they are missing one system, but no, they're not missing one system, but like, they have combined cardiopulmonary, like pulmonary and cardiac in one. Okay, what happens is, like, if we will talk about this one, musculoskeletal system, guys, this is the most common type of symptoms. More than 90% of the patient, they get these symptoms. Okay, so joint involvement is the most common clinical feature, guys, remember, in SLE. And that's, if you want to remember this thing, see, I show you this scenario in the start. Okay, this is the key to remember this thing. If you can remember this thing, of course you would know that the joint involvement is the most important clinical feature related to SLE. And see, in this one, there is lung involvement, okay, joint involvement, and CNS sign and symptoms are there, right? So see, like, this is the percentage game, like, and if you have this information, of course you can remember these things, right? So most of the time, it gives symmetrical small joint arthralgia. The joints become painful, they become red, okay, and they chronically, they become deformed. And what you can say, whenever there is major joint deformity, like, it resembles like rheumatoid arthritis, we call at this thing as Jacob's arthropathy. Okay, it is called as what? I will write over here. It is, okay, wait, I think I'll make it like this. um, Sorry, it is called as um, Jacob's. I'm going to set it up, guys. I'm just Jacob's arthropathy. Okay, so when the joint, they are, you can say, uh, deformed, and it looks like rheumatoid arthritis, we call it as Jacob's arthropathy. So Jacob's arthropathy in lupus. Joint deformities are reducible. There is no erosions. You can see in the X-ray, the joints, there is no erosion. See, all the bones are nice, and you cannot see much changes. Okay, so this is called as what? This is called as Jacob's arthropathy. So like this, you can see all these clinical features, you can see, and see, these are the most important ones. Okay, these are the most important one. So joint involved or musculoskeletal involvement is the most important one. Dermatological are the important one. Nervous system are the important one, and blood is the important one. Okay. uh, Raynaud's phenomena, Raynaud's phenomena, which is the discoloration of the uh, fingers and toes, You can see over here, um, see the reddish appearing one. Okay, so this one is like the triggers of this thing can be cold or emotional stress. Okay, so these are the clinical feature, guys, which you have to. So simply, if you will pay attention, on this thing, whatever is there, you know um, almost everything is involved, right? No matter it is CNS, it is CVS, it is respiratory, it is musculoskeletal, it is reproductive, it is gastrointestinal, it is hematology, it is nephrology, or like it is urology, it is everything is, and dermatology also. So all the systems are affected by systemic lupus erythematosus. Now I am going to go through the slides quickly. Um, as you know, like this is not my way, but like I had some comments from like on YouTube that you know like I'm scrolling down the slides and I'm not stopping. So actually, it's important to listen rather than read. You can see SLE is highly variable disease. At the beginning, only a single organ may be involved, or many systems may be affected, and early symptoms and sign of SLE may not be specific. And yes, very very important thing. See, guys, the general symptoms which I was talking about. So the patients can present with fever, weakness, fatigue, weight loss, and one more thing I will talk about is which you can put in hematology as well, but lymphadenopathy. Okay, so these are the things um, which the patients can present with. So these are, of course, the general, or you can say the general symptoms, or you can say the systemic symptoms. Systemic symptoms, right? All these are systemic or general symptoms. And then there is cutaneous manifestations. I explain all these things, right? I explained all this thing, and I show you this thing. I show you. Oh yes, oral ulcers can also be formed. Okay, oral ulcers can also be formed. So again, the rash. Why not to bring it in middle and make it enlarged? Okay, the rash. I show you this thing. Again, nothing new. Polyarthralgias, polyarthritis. Okay, and then I show you this thing. Musculoskeletal involvement, myositis can occur, dermatomyositis can occur, and I show you this thing which is the Jacob's arthropathy, right? So see, it looks like the patient has rheumatoid arthritis, a long-standing rheumatoid arthritis. So that's what I was talking about. And cardiovascular manifestations, we talk about that. I show you how Libman Sachs endocarditis look like. See, sterile deposits, right? So this one, cardiovascular manifestations, pulmonary manifestations, still pulmonary manifestations, again pulmonary manifestations, and of course, like fibrosis can occur in the lungs. And this is like this, they are showing you the CT scan of the lungs with fibrotic changes. Okay, and what how like interstitial lung diseases, there is a ground glass appearance. So this is the ground glass appearance. So of course the patients ultimately they can develop pulmonary hypertension, dyspnea, hypoxemia, restrictive lung disease. Okay, because there is fibrosis. So this thing, gastrointestinal manifestations, we okay, now here you can see I told you that there will be mesenteric vasculitis. Now anyone who is making the concepts nicely, they must know, like, see, whenever there is mesenteric vasculitis, what is going to occur? There will be necrosis, like, or point necrosis, which can ultimately lead to perforation. Okay, so this is how it is going to happen. So of course, like, they develop colitis with protein losing enteropathy. Lupus nephritis, like of course when they damage the kidneys. Okay, and now if you know what is glomerular nephritis, guys, this thing will be easy for you to remember, right? You know hypertension, you know edema, you know all these things, okay, which can occur. uh, Now this one is again classification given by International Society of Nephrology, classification of lupus glomerular nephritis. See, class 1, class 2, class 3, class 4, class 5S, and class 5G. S is for segmental diffuse, G is for global diffuse. And this is class 5, membranous glomerulonephritis, right? And this is class 6, which is advanced sclerosis, in which there is 90%, more than 90% of the glomeruli are involved. Okay, so this is how they present. And neurological manifestations, we already talked about this one. And okay. Now, neurological manifestations, hematological manifestations. Of course, there will be anemia of chronic inflammation. There can be hemolytic anemia, lymphopenia, neutropenia, thrombocytopenia, splenomegaly, and lymphadenopathy is common, which I included before, right? So, these things. And the patient may have serositis. Now, see, I was talking about systemic wise, system wise. I said pleuritis can occur. I said pericarditis can occur. So here they put it under the heading of serositis, right? Ocular manifestations. Now this is something interesting. So yeah, this thing we were missing. I already explained this thing, which is called as keratoconjunctivitis sicca. What happens is basically when the glands they are infiltrated by, um, you can say the cells, so they cannot produce secretions anymore. So not just the lacrimal glands, rather the salivary glands as well. So these are the people who have dry eyes and dry mouth, right? So it is seen in 10% of the patient of SLE with secondary Sjogren's syndrome, right? So they have like uh, retinal vasculitis, they may have fundus hemorrhage, they may have papilledema. And here they are showing you the photograph of the eye in which you can appreciate the hemorrhage, you can see the vasculitis. Okay, so that's all, guys, about the introduction and the clinical feature of systemic lupus erythematosus. And in the next lecture, we are going to talk about the investigations and the management. Okay, so thank you so much for listening.